Well, we'll go ahead and get started. Today, I think you're in for a very informative talk, and this by Mike McDaniel. And Mike is one that I think has led the efforts to bring interventional therapy for acute infarctions to Grady Hospital. He did a lot of work and spearheaded that work, and I think it's been a phenomenal success story. Mike comes from here. He went and got his undergraduate degree at the University of Georgia. Then he went to UNC. Got that reversed. He went to UNC first, and then came to University of Georgia, and then went from there to Emory and did his training here. He's been every site he's been, he's won some kind of award, whether it's AOA or Phi Beta Kappa or teaching award for a fellowship program, and I think it speaks to, you will see, an excellent presenter, and we're looking forward to this, Mike. Thanks.
Thank you very much. I really do appreciate it, and thanks for letting me be here and talk. This is we're going to talk about antiplatelet therapy and anticoagulation after PCI. And this is a daunting task to go through. There's so much data, so many drugs, and a lot to cover in an hour. So what we're going to really try to focus on is where the data is new. And really, there's four things that we're going to try to address. Today, with our contemporary stents, what's our optimal duration of antiplatelet therapy? And what's the role of our low-dose Rivaroxaban in patients with coronary disease? And then we're going to talk about the combination of anticoagulations and antiplatelet therapy, and then finally talk a little bit about Prasugrel and Ticagrelor. So I think one of the themes that you're going to see as we talk about this today is it's been a bad year for aspirin, and certainly some of the studies that we talk about today will only compound that. So let's start. The first question really we're going to try to spend some time with is, what's the optimal duration of dual antiplatelet therapy after you get a stent with our contemporary drug-eluting stents? And I want to show this slide just to start because I think it really helps sort of set the stage of where the data is. So the reason we put a patient on dual antiplatelet therapy after you put a stent in is to prevent stent thrombosis. That when you put metal in, it creates a hypercoagulable state, and there is a risk that that stent will clot without antiplatelet therapy. So we give patients dual antiplatelet therapy, but it's important to remember that the real vulnerable time period for stent thrombosis, this is looking at definite and probable stent thrombosis within the first year, is that you see it's really clustered within the first month. There may be a slight increase, maybe up to about 90 days, but after 3 months, the rate of stent thrombosis dramatically decreases and becomes a seldom event. The other thing to remember about stent thrombosis is not every stent that's put in has the same risk for thrombosing, and one of the most important predictors of thrombosis is the presentation. So if you look at where most of the stents thrombose in those first 30 days, it's actually the ACS populations, in particular the STEMI, the patients who have a lot of clot and a lot of thrombus at stent that have the thrombotic stent thrombosis events. Elective PCI today, it's almost unheard of to have stent thrombosis. The rates are 2 in 1,000 risk of stent thrombosis within the first 30 days. So important to remember the differences between presentation. Well, what do the guidelines say? We do have guidelines. The 2016 ACC AHA guidelines give guidance about dual antiplatelet therapy. And in those guidelines, the recommended duration of dual antiplatelet therapy for ACS is 1 year. That's whether you get a drug-eluting stent, a bare metal stent, no stent, or bypass. So it's kind of easy to remember. Now, that 1 year recommendation largely comes from the CURE trial, which was a large study, very well done, of acute coronary syndrome. And the combination of Clopidogrel and aspirin dual therapy improved the outcome of patients compared to one antiplatelet agent. But it's important to remember that this trial, there was actually only 20% of the patients got a stent. These were all bare metal stents and certainly not the contemporary stents that are used today. And it was published about 20 years ago. So the question is this data really still relevant today for our patients who have ACS? The guidelines have becoming more conservative by 2016 with stable ischemic heart disease. It was understood that The risk of stent thrombosis in stable patients, elective patients, was lower. And so the guidelines actually are class 1 for 6 months of dual antiplatelet therapy for patients with stable ischemic heart disease. Although in practice, I find this actually not often followed. The reason for the 6-month or a shorter course compared to more contemporary a year of dual antiplatelet therapy is that there were, by 2016, there were starting to become randomized trials that had looked at shorter courses, 3 to 6 months of dual antiplatelet therapy compared to what was the standard 1 year or 12 months of therapy. And what you saw is there wasn't any harm in terms of increased stent thrombosis by shortening the course of dual antiplatelet therapy. And when you looked at bleeding in total of these trials, that there was better bleeding if you shorten the course of dual antiplatelet therapy. Not too surprising. If you give less antiplatelets, you will always have less bleeding. Well, what about extended therapy? Because although there's a move towards shorter, there's still a lot of patients who are on dual antiplatelet therapy sort of indefinitely. They get the stent and are left on indefinitely. Now, it's important to remember that in 2016, the guidelines for that extended therapy is actually a pretty weak recommendation, a 2B indication, although it's, I think, pretty common practice to see patients left on dual antiplatelet therapy for extended times. Now, there is a rationale for keeping patients on dual therapy, and the largest trial that looked at this is called the DAPT trial. And this was a very important study published in the New England Journal in 2014. And what they did is they took almost 10,000 patients who got PCI. And then if you were doing well, you got up to a year of, everybody got a year of dual antiplatelet therapy. And if you were doing okay, you hadn't had a bleeding event and hadn't had a thrombotic event, they got randomized to either refilling the Clopidogrel or coming off the Clopidogrel and just going to one antiplatelet. So this is sort of a trial of refilling 2 medicines versus refilling only 1 antiplatelet agent at the year mark. What they found is if you kept patients on dual antiplatelet therapy, that there was less MACE events, there was less cardiovascular death and MI and stroke compared to single antiplatelet therapy, but it was a modest benefit and the number needed to treat about 63. But it's important to know that the technology changed during the course of this very large trial. And so over half the trial uses stents that we don't have today. They're first generation stents or they're off the market. And so when you go back and you look now at this DAPT trial and reanalyze it with the stents that we put in today, and in particular these everolimus-eluting stents, in the DAPT trial, there really wasn't a benefit to extended dual antiplatelet therapy. So those that were left on dual antiplatelet therapy didn't seem to do any better than those who were on single antiplatelet therapy. Now there's some nuances within the individual composites, but if you look at the MACE composite in total, not a lot of benefit. And not surprisingly, when you look at bleeding, if you kept people on 2 agents, they had more bleeding events compared to being on 1 antiplatelet agent. And so when you take the DAPT trial and then you take and you look at it in a meta-analysis with, so here's the DAPT trial with all the other trials that have sort of looked at shorter courses, 3 to 6 months versus the longer courses, at least a year, but usually 2 years or more. And you take it in total and you look at the mortality, what you find is that mortality actually favors shorter, or said the other way, mortality is actually worse by leaving people on extended dual therapy for long periods of time. And this is probably due that there's increased bleeding related mortality that's not offset by better thrombotic events. And so this data has sort of shaped a move towards, towards asking the question, is shorter dual antiplatelet therapy now preferred? And there were 3 major trials that came out over the last year that I think are worth talking about, kind of looking at this idea. The most important and certainly the largest was the TWILIGHT trial, made a big splash at ACC, over 9,000 patients undergoing PCI. They were randomized to 3 months. So we showed that curve that the first 3 months seemed to be the vulnerable period, but after that, less events. And so they were randomized to 3 months versus what was sort of standard 12 months of dual antiplatelet therapy. This was a population of stable ischemic heart disease and non-STE-ACS. They did exclude STEMI patients, so the highest risk. Everybody was treated with Ticagrelor or aspirin, so 2 antiplatelet agents. And then at 3 months, one group came off one of the antiplatelet agents. And in this time, instead of coming off the P2Y12 inhibitor, they dropped the aspirin. The other group stayed on aspirin and the P2Y12 inhibitor, and then they looked at events at a year. What they found is that if you got rid of the aspirin, that there was much better bleeding. There was less bleeding complications than remaining on aspirin. So one antiplatelet agent had less bleeding compared to 2 antiplatelet agents. So that's not too surprising. What was surprising and I think interesting is that there didn't seem to be a price to pay. When they looked at MACE events, death, MI, stroke, and stent thrombosis, that dropping the aspirin, there was no real price to be paid. There wasn't higher event rates. So there seems to be more harm without benefit with aspirin. Now this was with Ticagrelor. Another trial did a similar thing. This was the Smart Choice trial, also published this year in JAMA. Now it was about 3,000 patients, so slightly smaller, but still a good size. Again, patients undergoing PCI with drug-eluting stents, they did the same thing. At 3 months, they got randomized to either coming off the aspirin or continuing with a year of dual antiplatelet therapy. So half the patients had no aspirin after 3 months. This was a patient, the population was mainly Clopidogrel. About a quarter, though, were on Prasugrel and Ticagrelor, the other antiplatelet agents we'll talk about at the end. And there was a lot more ACS in this population, so STEMI was not excluded. This was really an all-comers trial. And again, when you look at bleeding complications, there is less bleeding with one antiplatelet agent. So without aspirin, less bleeding than compared to continuing it with dual therapy. And again, when they looked at the MACE events, there was no price to be paid by dropping the aspirin after 3 months. So again, pretty interesting, and it goes along with the TWILIGHT data. Now, even more interesting, and I guess more aggressive, is the STOP-DATE 2 trial, also published in the same issue of JAMA. Another similarly sized population, 3,000 patients, again, undergoing PCI, all comers. But what they did is even more aggressive at 1 month. So they knew that 1 month was really vulnerable, but then after a month, they stopped the aspirin. And this was randomized against dual antiplatelet therapy for 12 months. So at 1 month, half the patients stopped aspirin. There's a population that really reflects probably contemporary practice, mostly Clopidogrel, about 40% Prasugrel, about 40% ACS. And again, if you look at bleeding events, less bleeding without aspirin. And even at stopping at 1 month, no higher event rates in terms of MACE compared to the standard 12-month. And so if you take all this data together, you have almost 30,000 patients, 4 randomized trials, to looking at really short courses of aspirin. And so if you stop the aspirin at 1 to 3 months after PCI and then continue the P2Y12 inhibitor at that point, what you see is in total, when you look at bleeding complications, much better bleeding complications. Probably not surprising, 2 things make you bleed more than 1. But what's interesting when you look at the MACE events, really no higher MACE. If you look at MACE in total or stent thrombosis, no higher. And actually, when you look at the mortality trend, mortality trending into the direction of favoring shorter courses of antiplatelet therapy, kind of in line with the other meta-analysis that we showed. But the question is this the final answer? Is it 3 months for everybody? Do we really know what to do with our highest risk ACS patients? If you put a complex PCI, put a lot of stents into a CTO, is this answer this? What about elevated risk scores? So I think all of us know that DAPT should still probably be individualized. But the question is, can we do a better job in trying to figure out who these individuals are that should stop and who the individuals are that should continue? So there's 2 risk scores that I think are worth just talking about briefly. The first is the PRECISE-DAPT score. So there's an app. You can go download it if you want to right now. And it's a pretty simple app. It has 5 variables, looks at hemoglobin white count, your age, creatinine clearance, and prior bleeding. And it gives you a score that gives you the estimate of how likely you are to bleed on dual antiplatelet therapy. And so it gives you a number, it tells you if this is high, and it gives you an estimate of the bleeding risk on dual therapy. And this was derived from a pretty large population of patients randomized to shorter dual antiplatelet therapy compared to longer dual antiplatelet therapy. And so this is kind of a busy slide. It looks at the ischemic benefit of dual antiplatelet therapy, the bleeding risk with dual antiplatelet therapy. But the most important, I think, is to look at the blue, the net effect. Are patients being helped or harmed by the therapy? This is sort of the benefit minus the risk. And what you see is that if you look at the PRECISE-DAPT scores, most patients, there's not a big benefit to DAPT after 3 to 6 months, but there's a clear signal for harm if your PRECISE-DAPT score is high. So regardless of indication, ACS, or complexity of PCI, patients that have high PRECISE-DAPT scores seem to be more harmed than benefited by dual antiplatelet therapy after 3 to 6 months. And these are our population of patients that we should really be truncating dual antiplatelet therapy in, regardless of clinical indication or complexity of PCI. Now, the more common question is, all right, most of us are going to, that decision sort of short duration is going to be made mostly by the interventionalist in the recommendations in the CATH report. But for what most of us will see is in clinic, these patients are going to be coming back to clinic, and they've been doing okay, and they've been on dual therapy. And the real question is, who do you refill? So when do you refill both agents? When do you stop one of the agents and bring people down to single antiplatelet therapy? And there's it's sort of a different question in a different risk calculator. So there is another risk score called the DAPT risk calculator. It's you can get it online. It's derived from the DAPT trial that we showed earlier, and it has several variables, some of them negative, some of them positive, and gives you a risk for events, both bleeding and ischemic events. And so when you go back and you use this DAPT score in the DAPT trial and look at the patients that we're using DAPT in today, the everolimus-eluting cohort, what we find out is if your DAPT score is low, less than 2, that these patients seem to be harmed by refilling the dual antiplatelet therapy. And when you look at MI and stent thrombosis, there's no benefit. But when you look at bleeding, there's more bleeding on dual therapy, and there's more or worse mortality. So net harm by refilling the prescriptions in this population. Now, on the flip side, if your risk score is 2 or above, there is probable benefit, and these are patients to at least consider continuing them on. In this cohort, if your risk score is 2 or above, there was a reduction in myocardial infarction and stent thrombosis with two agents compared to single antiplatelet therapy, and at least in the cohort was not associated with worse bleeding. Now, benefit minus without risk should lead to better mortality. For whatever reason, dual therapy, even in this group, still didn't improve mortality. Now, I say that because we're going to talk about something in a minute, but it's just worth noting this may just be a fluke of the data, and if we had a lot more trials that looked like this, we would see a mortality benefit. But I'd say this to say that we're still looking for a good risk predictor that says who is living longer by dual therapy, and even the DAPT score is not doing that here. So if we say, what is the optimal duration to try to put all this back together? What is the optimal duration of dual therapy after PCI with contemporary stents? Remember, the guidelines are 6 months in stable disease and 12 months in ACS. That's the guidelines. But I think this data is really showing that most patients probably only need 3 to 6 months. And instead of stopping the P2Y12 inhibitor, it looks like the data is suggesting that maybe we stop the aspirin, at least within this first year. And if you have to, like for our highest risk patients, they may need surgery and they've just put a stent in, probably after a month, in that first 1 to 3 months, it's probably fine to interrupt for surgery. I think DAPT should be individualized. We all would probably agree with that. But the important thing is to remember that few patients benefit from extended therapy. And we see a lot of patients on extended dual therapy. And I do think that we should probably be doing precise DAPT score calculations and DAPT score calculations. And I would encourage our group to put these in the PCI reports to help guide. But if it hasn't been there, you know, these are risk scores that you can download, very easy to do to help try to guide whether we should refill medications. It's pretty clear that there's harm if there's precise DAPT scores are elevated. We really want to go to the shortest amount of antiplatelet, even if it's complex PCI in these populations. And again, refill after a year only if the DAPT scores are elevated. So that was a lot. Now, just to shift gears slightly, I think we could also question maybe dual antiplatelet therapy after 3 months should never be done. And if we need extended dual therapy, maybe we should try a different approach and combine an antiplatelet with a low-dose anticoagulant, and in particular, Rivaroxaban at low doses. So Rivaroxaban is an anticoagulant. Normal dose is about 20 milligrams, so this is 2.5 twice a day, so a very low dose. The theory is, so here's a patient with the ACS. This is a coronary artery. Here's the thrombus. And if you take the thrombus out and you look at these lines of Zahn, these are what we see under the microscope. There's platelets and fibrin alternating with red cells. And so the theory is, instead of giving an antiplatelet to attack this and then another antiplatelet to attack that same mechanism, why don't you attack the antiplatelet and the anticoagulant? So maybe would you get better benefit by different mechanisms of action? Makes intuitive sense. Now, there is some data that's suggesting that maybe that's the case. So the COMPASS trial is probably something a lot of us are familiar with. It's a very large study, very well done, stable CAD. Now, in that population, there was a 3-way randomization, but we're just going to focus on this randomization of antiplatelet versus antiplatelet and low-dose anticoagulant. And there was a benefit with the combination compared to single antiplatelet therapy. Now, this was a modest benefit. It was a MACE composite, and the number needed to treat of about 77. So modest benefit, similar to what we've seen. What was interesting is the trial was stopped early because of this benefit. And what was interesting is what drove the benefit. Unlike the DAPT data, where there was no mortality, there was a mortality reduction with this dual therapy compared to aspirin, and also a stroke reduction. And this data was also similar to another trial called ATLAS that also looked at that similar combination. So very intriguing in what drove the MACE, because we weren't seeing this in the DAPT data. Now, before we get too excited about it, anytime we combine 2 things that make you bleed and compare it to 1 thing that makes you bleed, 2 things make you bleed more than 1 thing, and certainly we see that here. So there is certainly harm in this approach compared to being on just single antiplatelet therapy. Well, this is really intriguing. It really doesn't help us answer the real question which we want, which is, if we were going to continue somebody on dual antiplatelet therapy, if we had done a DAPT score and we said this person's high enough risk to continue 2 agents, really what we want to know is, what about 2 antiplatelet agents versus an antiplatelet and an anticoagulant? And this trial did not answer that. But there was one other trial. It was a small trial that, and it was an ACS population, so slightly different population, that did do this dual antiplatelet therapy versus an antiplatelet and low-dose Rivaroxaban. And the punchline was no benefit. There was the similar amount of MACE, similar amount of mortality, similar bleeding. So although it's very intriguing, and I'd love the idea of combining 2 different drugs with different mechanisms of action, this is a little bit, I think, sobering, and I think we need more data. So when we go back to this question, because this will come up a lot, we are seeing a lot of patients being already put on a low-dose Rivaroxaban. Is this a preferred strategy? And I would have to say, I don't know personally. It's intriguing to see this mortality signal. It's a very well done trial, but when you compare it to dual antiplatelet therapy, it may not be any better. It's certainly more expensive and twice a day. So hard to say that we should be moving all of our patients to this strategy at this time. So shifting gears, and I want to make sure that we have, because this is a lot to go through, so I'm already apologizing. So I do want to make sure that there's time to discuss this, because there's so much here. So the third question here is, what is the optimal antiplatelet regimen when anticoagulation is warranted? So this is the AFib patient, and they get a stent. So they have an indication for anticoagulation, and they have an indication for DAPT. What do you do? And I think we're now finding a pretty strong signal that getting rid of aspirin is the thing to do. So there's now been several randomized trials, over 10,000 patients, all randomized, that looked at the triple therapy strategy. So anticoagulation with DAPT versus get rid of the aspirin, just do a P2Y12 inhibitor and anticoagulation. 2 versus 3, double versus triple. And if you get rid of aspirin, you have less bleeding. And if you get rid of aspirin, there doesn't seem to be a lot of price to be paid in terms of MI and stroke. And so this is a pretty clear signal now from 5 randomized trials. And I think this has really become now the standard of care for most patients. There was also a question is what's the best anticoagulation strategy to use when you put a stent in? And like most of our data, I think that the data is now suggesting that our newer oral anticoagulants like Apixaban are preferred. This is the AGUSTUS trial, looked at Apixaban versus the vitamin K antagonists, and less bleeding complications if you use the newer agents. So these DOACs or NOACs, however we want to call this group, seems to be the way to go with a P2Y12 inhibitor without aspirin. Where there's a little bit of new data is, well, as you start to look at these meta-analyses, what you are seeing is there is more stent thrombosis when you drop the aspirin. It's a 67% relative reduction, but because these numbers are so small, the absolute benefits, I mean, the absolute risk is pretty low. But what's interesting, again, just like we showed in the earlier slide, is that where the risk is early. So when they looked at when you drop your aspirin in these strategies, that the risk of stent thrombosis is highest in the first 30 days. 80% of all the stent thrombosis was within the first 30 days. And that fits with the first slide we showed. The biggest risk of stent thrombosis is these first 30 days. After that, stent thrombosis risks really dramatically decrease. So how do you put this together? What's our optimal antiplatelet therapy when we need to also give anticoagulation? It looks like triple therapy for the first 4 weeks is still pretty reasonable if the patient's at higher risk. So if you've had an ACS, complex PCI, we're still putting a lot of patients on 3 agents, aspirin, the P2Y12 inhibitor, and the anticoagulant. But then dropping that aspirin after that 4-week period and just continuing with dual therapy, the P2Y12 inhibitor like Clopidogrel and anticoagulation. The NOACs or DOACs are preferred anticoagulation over Warfarin. And we should remember to probably think about routine PPIs. We always get concerned about this interaction theoretically with Clopidogrel, but all the data suggests that patients who get PPIs do better. They have less bleeding and there's not higher event rates. So I don't think there's anything to be fearful with in that with Clopidogrel. Now the real question though, and this is I think where most people are going to see these patients. All right, they've done well. They've gotten their stent. They're on anticoagulation. They're on Clopidogrel. They had a great year. And they show up back in your office. The stent was a year ago. Now what? They have an indication for anticoagulation, like atrial fibrillation. They have an indication for antiplatelet therapy, coronary disease and PCI. So indication for 2 things. Do you give them 2 things? And what we're seeing is the data is suggesting we should probably be much more reserved with 2 agents. We should probably be dropping antiplatelets altogether in a lot of our patients. This is registry data, patients who need anticoagulation and also have an indication for antiplatelet therapy like CAD, and the PCI was not reasoned. What you see is in these registries after adjustment that hospitalizations and bleeding are much higher with the combination of anticoagulation and antiplatelet compared to just anticoagulation alone. And this is not associated, again, with higher event rates by dropping aspirin. Now, this is registry data. Is this confirmed in randomized trials? Well, this group set out to answer that question, and they were able to only randomize 700 patients. This was a group with atrial fibrillation. They had had their PCI. They got to the 1 year mark, and then they got randomized. Do you keep them on an antiplatelet, or do you just stop antiplatelet altogether and just do anticoagulation? And there was no benefit to continuing the antiplatelet, but they had to stop this trial early because of difficulty enrollment. And what's interesting is the discussion of it, is they say the difficulty in patient enrollment mainly stemmed from the substantial reluctance of cardiologists to withdraw antiplatelet therapy in stented patients. And I think it's just important for us to remember that antiplatelet therapy has been such a mainstay of cardiology for so long that it is really hard for us in cardiology to think about getting rid of this therapy. Fortunately, in New England, also this year, though, a group was able to do a similar trial, larger, was able to complete it. Atrial fibrillation patients treated with contemporary stents and also treated with contemporary anticoagulation strategies, randomized to refilling the antiplatelet and the anticoagulation, or just refilling anticoagulation and stopping antiplatelet. And again, there was better outcomes if you only kept patients on anticoagulation, and this was driven primarily by better bleeding complications. So less bleeding and better outcomes with just monotherapy anticoagulation. And this sort of makes sense because a lot of our patients with atrial fibrillation are older, and a lot of patients, and as you get older, the risk of bleeding with these agents becomes much higher. The guidelines, at least the European guidelines, have recommended discontinuation of antiplatelet therapy and just treating with oral anticoagulation at 12 months. It's a 2A indication. We don't have any ACC guidelines. So what do you do when antiplatelet agent at 12 months after PCI? And the answer, I think, is looking like we should drop all antiplatelet therapy, aspirin altogether, in most of these patients, and just continuing on the novel oral anticoagulants. So last question. I know this is a lot, so we'll try to wrap it up and get to questions. So Prasugrel and Ticagrelor. These are two antiplatelet agents in ACS. Who should we give them to? Because I bet you see a lot of variation in practice here. So Prasugrel, it's a P2Y12 antagonist. It's an antiplatelet like Clopidogrel. It's a prodrug like Clopidogrel. It requires metabolic activation. So when you take it, the body has to break it down to its active agent, but it's more efficient than Clopidogrel. So just taking a step back, how does Prasugrel stack up against Clopidogrel and ACS? The TRITON-TIMI 38 trial was the landmark trial, very large trial, over 13,000 patients, moderate to high risk ACS, undergoing PCI. Patients randomized to Prasugrel had better outcomes, better MACE compared to Clopidogrel, and they had higher bleeding. Now, the one thing just to note in this is the benefit was about a 2% absolute risk reduction. The harm was about a 0.6% increased bleeding. So 2.6. I'm going to show you why that matters here. So the other drug in this is Ticagrelor. It's a direct acting drug. It does not require metabolic activation to its active metabolite. So it has very rapid onset, and it's reversibly bound and faster offset. So Ticagrelor was also compared to Clopidogrel, and this was in the PLATO trial. Very large study, very well done, over 18,000 patients, again, randomized to Ticagrelor or Clopidogrel. And what you see, just like the other trial, about a 2% absolute benefit. So just like we saw before. Now, where we got led astray was that there was not any higher bleeding. So they used a different bleeding definition in PLATO, and it was touted that Ticagrelor had benefit without bleeding. But when you go back and look at the same bleeding definition that they used with Prasugrel, there was higher bleeding with Ticagrelor, and the bleeding increase was 0.6. So from the get-go, Ticagrelor and Prasugrel had the same benefit and the same risk. But based on this data, Ticagrelor became the leading antiplatelet agent used in this country, and very few were using Prasugrel after this time. The guidelines said it was a two-way indication to use Ticagrelor or Prasugrel over Clopidogrel. So it was recommended over Clopidogrel and ACS. But this doesn't, did this answer the question, which is better, Prasugrel or Ticagrelor? So now we're starting to see head-to-head data. One of the trials looked at over 1,200 patients in STEMI, our highest risk patients, randomized to Prasugrel and Ticagrelor. And what they had to do is stop the trial because of futility. It showed exactly what the other trial showed, is there was the same amount of death, bleeding, and myocardial infarction with the two agents, which is what you would have anticipated with the original data. More interesting, though, in New England just of this year was another trial, a little bit larger. This was an all-comer ACS population, again, randomized Prasugrel versus Ticagrelor. And again, when you looked at bleeding, there was no better bleeding with Ticagrelor. They were the exact same, in fact, trending in higher with Ticagrelor. So again, showing you that there is no safety benefit to Ticagrelor, which is why it was sold and became the market leader. What was interesting is that the MACE data, when they looked at MACE, there was actually superiority of Prasugrel compared to Ticagrelor. And we can talk about why this may be the case in this trial. There's probably several different reasons. But one of them is that there's other side effects of Ticagrelor that lead to drug discontinuation and poor compliance. So when you look at the PEGASUS trial, or most of the data with Ticagrelor, almost 1 in 5 have some complaints of dyspnea. And this leads to clearly higher drug discontinuation. And these patients are on a twice-a-day agent that causes dyspnea. This can lead to drug discontinuation and perhaps at least be partial explanation for why there's better events with Prasugrel, perhaps due to better compliance. So although Ticagrelor has been the market leader for the last few years, I think if we had to say today which is better, it's kind of gone back the opposite way, that Prasugrel is probably preferred. It's once a day compared to Ticagrelor, that's twice a day. It doesn't make you have higher bleeding higher rates of trouble breathing. It doesn't cause dyspnea. It's just as safe, and it may be better, at least in the head-to-head data. So the last thing is there a role for Clopidogrel? What about Clopidogrel? I bet a lot of people see Clopidogrel in ACS patients. Is there a role? Remember, we said the guidelines recommend against it. They recommend these other agents over it. But it is important to remember Clopidogrel is a prodrug like Prasugrel. And if you're a carrier of the CEP2C19 reduced function allele, which means that you can't metabolize Clopidogrel as well in the liver, that you find that the Clopidogrel doesn't work as well. And this is a gene that's seen in about a quarter or maybe a little bit more than our population. But the majority of patients don't have this gene. And so if you go back to this original data of Clopidogrel versus these newer agents, where Prasugrel looked better, but then you stratify it again by whether Clopidogrel worked or not, what you find is that if you can metabolize Clopidogrel, you've got the genes to metabolize, and it gets metabolized, Clopidogrel works just the same as Prasugrel. But if your Prasugrel doesn't work, if your Clopidogrel doesn't work, if you don't have the genes to metabolize it, then it doesn't work as well. And not only is Prasugrel better, it's a lot better than what we saw in the trial. So this benefit of Prasugrel, and the same holds true for Ticagrelor, this is really about Clopidogrel response. So Clopidogrel responders do just as well with Clopidogrel. And now we see randomized data that's confirming this. So this is a modest-sized trial, a STEMI, randomized to Ticagrelor or Prasugrel, or a genotype-guided strategy of Clopidogrel. So they tested the Clopidogrel, they made sure it worked, and if they worked, they gave it to these patients. And if you got Clopidogrel and the Clopidogrel worked, it was just as safe, in fact, trending towards better compared to Ticagrelor or Prasugrel. And this was really driven by nuisance bleeding or minor bleeding. So there may even be a little bit of a benefit to giving patients Clopidogrel if it works in terms of less minor bleeding. And certainly we see a lot of our patients come back and they're black and blue all over their arms, and they're complaining of how much they're bleeding. And so if we can get patients on a little bit less antiplatelet, and it may be beneficial. Just to know, there's other ways to test whether clopidogrel works. The other way to do it is to test not the genes, but how are the platelets responding? How are the platelets, what does platelet aggregation look like? We could spend a whole talk about the different ways of doing this. What I'll just tell you is the Verify Now P2Y12 assay is the one that's used in clinical practice, not because it's the best, but because it's the easiest to use. And when you look at patients who are randomized to using platelet function testing compared to everybody getting Prasugrel, you see that ACS patients who get clopidogrel do just fine, in fact, trending towards better as long as the clopidogrel works. So in these strategies, you test it, you give clopidogrel if it works, and only if it doesn't work, then you give these newer agents. So how do we wrap this up in the ACS? Prasugrel seems to be preferred over Ticagrelor today. And clopidogrel seems to be, as long as you're doing genetic testing or platelet function testing, it's at least as good as Prasugrel. It's cheaper and possibly even better with less minor bleeding. And I think Ticagrelor is probably reserved for patients who are non-responders to clopidogrel and have a contraindication to Prasugrel because of TIA or stroke. So the final slide, and then maybe we can just open this up for discussion, because I know this is a whirlwind topic, ton of data here, and I apologize for that. But I think the conclusions are, really think about dropping the aspirin. After 3 to 6 months, most patients and many patients after PCI, that's all that's needed. And long-term in our patients who have anticoagulation, this is mainly our AFib population who are often older. I think it's important for us to remember a lot of patients are out there on dual antiplatelet therapy, and few patients actually benefit from extended dual antiplatelet therapy. And while we don't know the absolute best way to guide this, we should probably consider using these risk scores. They're probably our best guide at this time, the PRECISE-DAPT score and the DAPT score, to probably help answer this. So before you hit the refill on the clopidogrel or the aspirin, think about these risk scores. And I think clopidogrel is still a great drug in ACS as long as you know it works. So you can't know it works unless you test it, either by platelet function testing or genetic testing. And we could talk about which of those two strategies is better maybe in the discussion. And I think now Prasugrel's become our preferred agent in the non-responder population. So it's fine to give everybody Prasugrel, or it's fine to give patients clopidogrel as long as you know it works in ACS. And both are once-a-day agents, and clopidogrel certainly generic and cheap. So with that, thank you. Whirlwind topic, and I open it up for questions. Thank you. Clear as mud.
Thank you, Mike. Appreciate all your comments. This is something I think, I'm speaking as a cardiologist, but as I look around, it affects all subspecialties. And that you'd see these patients coming in, and the big question always at the end as they're trying to fill out their med sheet is, well, what do we do with the clopidogrel or Prasugrel? What do we do with these drugs? And I think Mike is telling us that we probably overuse them. We have gotten comfortable with them, and it's easier sometimes to leave the things on the chart and change it. But I think that his points that this is an individualized thing that you need to think about, recognizes the difference between acute coronary syndromes and stable angina. That's one of the big differences. Make sure that you're recognizing that and not use everybody the same. So sure, there must be some questions here.
Hey, Mike, thanks very much. That was a great review. Question I have around the drop the aspirin, and maybe I just missed some of the data. Like, have there been any studies where they drop what I'll call the potentially more expensive agent rather than the aspirin? I mean, is it matter that we're dropping
Yes.
one particular agent over another, and reading between the lines of why we dropped the cheaper agent versus the more expensive?
It's a great question, and the short answer with concrete data, we don't know. And so we're going back to older data like credo of aspirin versus clopidogrel, which of those is better. And I just don't know that we're able to look to answer that. What I can say is that there are some meta-analyses that have looked at short courses in ACS that led up to these trials. And in all of them, there was neutrality on mortality because you were just trading bleeding and ischemic events when you dropped the P2I12 agent. But these newer trials, they dropped the aspirin. And what you saw is that you weren't just trading events, you were moving the curve towards better. It doesn't answer, it's comparing apples and oranges, but I guess what I would say is that it does suggest, at least in ACS patients, that there may be a better strategy to keep the P2I12 in that population. Now, with stable angina or stable ischemic heart disease, I honestly believe there would be no difference. I couldn't imagine you'd find a trial that would show that there's a benefit to dropping aspirin or dropping P2. I would think they'd be the exact same. It's really the ACS patients that there's still a question. So I would say in ACS, I would drop the aspirin in favor of the P2I12 inhibitor. The real question that this asks, which there's no answer, is if you were going to take one antiplatelet agent for whatever it was, for stable CAD or you've had a PCI 5 years ago, you're going to take one antiplatelet agent, what would it be? Would it be aspirin? Would it be clopidogrel? Both of those are very cheap. You know, clopidogrel used to be expensive, but it's still pretty cheap. It's not pennies like aspirin, but it's really cheap in the grand scheme of all our medicines. So both are really good. Which would you pick? And I don't know that we know the answer to that question. And then last thing that brings it up, though, is that would it matter if you knew if you were a clopidogrel responder? And so we're seeing a movement towards maybe there's less bleeding with P2I12 over the aspirin, maybe. But would you want to be your only antiplatelet agent, clopidogrel, if you were a clopidogrel non-responder? So it's bringing up a whole new area for us to look at, is maybe we should be doing this genetic testing not only to help us decide whether we're going to give clopidogrel or ticagrelor, but maybe as we think about what's the best strategy. And if I were a clopidogrel responder and I was going to pick one agent for me, maybe I'd pick clopidogrel. I don't know.
One question I had, and you sort of just answered it a second ago, but what role is there for testing, for genetic testing or platelet function testing, not in the acute setting?
It's a good question, and the short answer is probably not a lot. The reason for it is, one, stent thrombosis rates are very low in stable ischemic heart disease, so it's hard to move the curve and be better than clopidogrel because the event rates are so low. There have also been some data that have randomized patients. So there's what's called trigger PCI and gravitas that have looked at the stable patients and randomized patients to testing, and then either doubling the clopidogrel dose if it wasn't a responder or changing them to Prasugrel. And neither of those strategies worked in the stable population. And it's probably because the event rates are so low and we randomized an extremely low risk population. And so in total, there's not data for that. With that said, it all comes back to what single antiplatelet agent would you want to take if it was you or your family member, or, you know, what would you, aspirin's certainly been the one that we've done. Would you think about clopidogrel? It may be slightly better. Would it matter if based on your age? Maybe we need to have a different strategy for our young patients versus older patients. So there's more questions than answers there, unfortunately.
As a non-cardiologist, how expensive is the genetic testing? And is it, I assume it would be a one-time test, but does that ever change? Not your genetics change, but your responsiveness to the clopidogrel?
Yeah, that's a great question. So the genetics don't change. The genetic test is about $150. And most of that would be done in a hospital, so under usually DRG, but there is reimbursement if you have insurance as an outpatient. But most of this is probably done at that index hospitalization when the stent was done. For platelet function testing, it's more complicated. and it does matter. And so you can change. And so when people have looked at it over time, the response does change. And so the answer at time 0 could be a little bit different than time 30 days, which may be a little bit different than. So that's why there's a thought that genetic testing is easier, because it's yes or no. And it's not really variable, and it never changes. So a lot of people like that, and the data is a little bit stronger for it. But I see why people like platelet function testing, because it's cheaper. It's $40, and so that's why it's done. I think you're going to see a movement towards testing towards genetic, though. I didn't get into it, but if you test to test platelet function testing, you actually have to give Clopidogrel. So you have to give Clopidogrel, load it, take it, and then see if it works. The opposite way around is you could give Prasugrel, because it's quicker, faster, and then only downgrade, or what's called de-escalate, based on genetic testing. And you can test if you're a Clopidogrel responder genetically, no matter what medicine you're on. So I think there's a movement for a lot of reasons to do genetic testing. I say that because we don't have genetic testing at Emory. So I think it's the right thing to do, and we don't have it. So we can talk about maybe getting that. So anyway.
Thank you very much, Mike. We appreciate it.